you so much, Dr. Gaurav, and congratulations, Drishtikon Institute, for completing your 25 years. And thank you so much, Uttarakhand Ophthalmological Society, Dehradun Ophthalmological Society, for giving me this opportunity. In fact, I was just discussing with Dr. Saurabh that when I came back to Ambala, started my practice, my first paper that I presented was in Dehradun only. And it's been very close to my heart, and I'm really proud to say that I have won Dr. MC Luthra gold medal twice, and that is very, very close to my heart. So when Dr. Gaurav told me to present on ASOCT, to me, as an anterior segment surgeon, OCT, specifically cornea surgeon, is something like, what MRI is for a neurosurgeon. So we are going to see just 500 odd microns, and it's great that we have so much technology these days that we can dissect it even up to 5 microns level. So I generally enjoy doing it, seeing it, and let's see if we can do justice. So what I'm going to cover is, let's see, what are different types of OCT, history of OCT machines, what is the physics behind OCT, how does it happen, and how do you operate individual machine. So all these things I'm not going to cover. So in case you are very much interested, please call a machine wala person. They'll be very happy teaching you all these things. I am going to do is just I'll show you 2 slides. तो उधर जाना है क्या? Just a minute. मिरर करते हैं. Where is it? Display. यहाँ से स्लाइड शो करना है. रेफरेंसेस देखना है. ये डिस्प्ले पकड़ नहीं आ रहा है. आपके पास दूसरा तो वो लगा लो ना मुझे. अच्छा मेरा नहीं लगा है. ऐसे चला लेते हैं. I think we can carry on with this only. So I am going to show you just 2 slides for that. Mainly I'll just cover that how do I use OCT in my practice. So the 2 slides are, one is that these OCT, the different, how it basically what we are looking for is a penetration. In MRI it penetrates for around 1 mm, and in OCT we goes around 10 microns, even up to 5 microns. So up to 10 microns we can see that particular tissue. That is what the OCT gives us. So this is how it developed. So basically what is the basic difference is number of scans per second. So when it came early, the time domain OCT, it was 512 axial scans, and now in Anterior or the swept source OCT we can scan up to 2 to 3 lakhs scan per second, and you can see the resolution goes down to even 5 microns. We have 2 systems. We have Octa, that is this Fourier domain, where we have 29,000 scans per second, and now recently acquired Anterior. So Initially we used to do cornea OCT on OCTA itself, but now ever since we have got Anterior, most of our traffic of anterior segment has shifted to Anterior, and this is now exclusively for retina. For this, in case you want to do an anterior segment OCT, you'll have to put up a special lenses, while in this you don't have it. So I'll just take you through a few cases. So this was a 24-year-old gentleman, and he had a dimness of vision in both eyes for 1 year. He has recently joined an IT company, and this is what his cornea looked like. So this is typical granular dystrophy of superficial variant. You can see BCVA 636. So we did an OCT, and we found that these lesions were within 100 odd microns. So which means if your epithelium is around 50 to 60 microns, you can always go ahead and do a PTK of close to 50 microns. So what we did, we generally do a PTK in 2 sessions. One is 30 microns, and then we see if the iris details are visible. If not visible, then knock off another 20 microns. So we went ahead and did a 50 microns PTK for this patient, and you can see it improved to 6.9. So this is how the OCT helped me in planning my surgery. Another lady who had undergone LASIK elsewhere, and she had undergone LASIK around a decade back, and she presented to us for a blurry vision since 1 month. She had a small trauma while sipping a cold drink with a straw, and after that she had undergone a few surgical intervention also. And when I saw her first, this is what she was. So no prizes to diagnose that this is epithelial ingrowth. But what was bothering me was that how did this epithelium, from where this epithelium is going inside? So we couldn't find it on slit lamp. When we did an OCT, of course, this is a flap around 120, 130 microns, and then there is this chunk of epithelial cells. What we found was this. In this area, there was no flap. So that means it's direct. So there's a hole. So when we went back and saw, this was a hole in the flap, and from where this epithelium was going. So you can see the hole. So after that, we went ahead, removed this, and the patient improved. So while doing this wash, we were quite conscious about where is the hole, so that that doesn't get extended, that doesn't get tear. So this is pre-op and post-op OCT of same lady. Another case, 5 years old gentleman. He came with a recurrent redness, pain, watering in one eye only. And when we saw the cornea, there were many spots. It was like capes on the epithelium. So this were when we did an OCT. You can see this is exclusively in the epithelium. Very typical of microsporidia keratoconjunctivitis. You can't, once you have this OCT, you can't, confuse it with nummular keratitis. All you have to do is remove these lesions, just debride it, and the patient becomes absolutely all right. So no need to give steroids or anything else. Compare it with adenoviral keratoconjunctivitis. Here, these lesions are below the epithelium. So that's how the OCT becomes almost diagnostic in picking up whether it is in a microsporidia or nummular keratitis, although the confusion is only in 5 to 10% of the cases. Another patient, he had the healed fungal keratitis, and this is what he was left with, 2400. The scar was in anterior 180 odd microns, and this patient is, I think, more than 12, 13 years old. So we thought that maybe at that time, we thought that why to do a full PKP? Use a microkeratome that we used to use in those days, create a free cap. This is 180 head that I used because the scar was in anterior 180 microns, and remove this flap. This just create a free cap kind of thing, and then created the same thing on a donor's eye, and just change this flap. So there's a new flap that has come. So this we call superficial anterior lamellar keratoplasty. So you can see the patient has improved to 2400. The scar is replaced by a transparent normal collagen in the form of anterior stroma. These days we have femtosecond laser, so we can always go ahead and do this anterior lamellar surgery using what we call FALK or femtosecond assisted anterior lamellar keratoplasty. Here the OCT is going to help us that how deep you want to go. So you can see the patient who had undergone FALK. Unfortunately, this is one of our FALK patient who presented with sudden edema. So one is the OCT helped us in planning the surgery. Now let's see. In the post-op, during I think follow-up of 6-7 months, he developed something like this. So we thought that whether it is HSV or what it is, why this has become so much edematous. So when we did an OCT, you can see the fluid was accumulated in the interface, and the graft was swollen. Very rare case of stromal rejection after FALK. Generally, after anterior lamellar keratoplasty, it's very rare to see this rejection, and this is what we could diagnose, gave steroids, it was fine. I'm sure the refractive surgeons here would remember this kind of picture. This is any refractive surgeon knows what it is. So this person had had undergone LASIK elsewhere. After 1 month, developed a dimness of vision, and then he was diagnosed as regression. He had developed minus 2.5 or so. So they planned to do an enhancement. Before that, this is a very good friend of mine. He said, Vikas, can you have a look? And when we saw, there was a fluid in the interface when we did an OCT, and the pressures were 35. So this was actually steroid responder, when this was the only area from where the fluid could accumulate, and we stopped his steroids, gave Dimox, and he was perfectly fine. So the OCT can be used in a gamut of area. What you can image is, you can image cornea, conjunctiva, tear film, contact lens interface, angles, lens, iris, and these days even anterior vitreous. So all those things you can image, and it can help both in diagnostic as well as therapeutic. So refractive surgery, suppose you want to do an enhancement, or you somehow want to know what is the LASIK flap thickness. You can go ahead, suppose the patient is underwent surgery elsewhere, you can definitely go ahead and see what is the residual bed, what is the thickness of the flap. And suppose you have done an ICL, after that you need to know what is a vault, because if there is any problem. So what we generally do is, we don't do ICL in one sitting, both eyes. So we do in one eye, check the vault, and then do the other eye. So this is the anterior image. You can see from the penetration is pretty good, even from anterior surface of cornea to PC. You can see this is the vault, and this is the image from using Octa. You can see what is the vault. So you can see what is the vault. If there is anything you want to make some changes for the other eye, you can go ahead and do it. RK incision, suppose status post RK, you want to do a cataract surgery. What is very important is how deep are these cuts. Suppose where you want to make an incision and these cuts are very deep, you need to be careful, because these can rip away, and you might have to use sutures. Ectasia, where the OCT is really helpful for us is when we see the patients of high drops. So high drops, where is the cut in the DM, how much it has separated, whether you have cleft, what do you want to do? You want to do a desmetopexy, you want to see it on conservative, or you want to do any compression sutures. Sometimes you see such big clefts. This was a patient who had undergone C3R, and after C3R developed a high drops. Again, this is a rare thing, but these kind of bad clefts, so many clefts, you can plan what you want to do. Even just on the basis of OCT, you can know where is the separation, which layer of DM has separated, whether it is a pre-desmetic layer or it's a desmetic layer, because there your intervention as well as your prognosis, you can prognosticate how this patient will do. So these days we do use compression sutures for our high drops patient. They do very well, and here again, to know where is that cut, where is that tear, that really our OCT really helps us, because we want to do this compression sutures perpendicular to that cut. There's another patient who had undergone compression sutures for high drops. This is a patient I saw last month, PMCD, very bad PMCD, very severe PMCD, and along with PMCD there was high drops. So you can see that. So here this cornea is very, very thin. This was hardly epithelium and DM, that's it. So C3R, if you do collagen cross-linking, you do post-operative OCT to know where is the demarcation line. Demarcation line tells you that yes, there is a cross-linking has happened. Generally, it's in the mid to posterior stroma. There you can see the demarcation line. If you have done intacs, it is important to see the stroma posterior to the intacs is at least 100 to 120 microns, because if it is less than that, you can have a melt. So again, in post-operatively intacs, we do OCT in all our patients. Dystrophy degenerations, pterygium. So this is the pterygium, and this tissue is under the epithelium. This is very important. So you can see this is, and it is attached on the cornea. If you see the pseudopterygium, there's a gap. So pseudopterygium has come and just got attached, but in the base it is not attached to the cornea. The treatment is different. Here you don't really have to do a CAG, but in pterygium you'll have to do a CAG. Pingicula, if the patient is really fussy and say what is it, you can scan and showing that it's absolutely fine. So pingicula per se, the OCT is not going to help you in any way. It's just for documentation purpose. Where it is extremely helpful is when you have a suspicion of OSSN or surface neoplasia. Here, this mass is within the epithelium, while in pterygium, it was under the epithelium. So this is, if you have a suspicion of OSSN, OCT is really diagnostic and it helps a lot. Rather, we can even find that whether it is an invasive OSSN or intraepithelial neoplasia. Spheroidal degeneration, these lipid vacuoles you can see it from the OCT. You can plan if there is a scar down there, you can plan your PTK, just like I had shown you in granular dystrophy. This is an anterior image. You can see the whole cornea, you can see, because the penetration is very good, and you can take even 16 mm diameter. And this is a patient who had spheroidal degeneration. We removed these lipid flocules and then did a PTK, and the patient improved very well. Salzmann nodules, because these are patients where you have partial LSCD and these nodules are just under the epithelium and raised up. So, and it's very easy to find the plane when you are removing it. Sometimes patients are very disturbed with the vision if you have these kind of irregularity, and if you remove it, patient becomes absolutely fine. Any idea what is it? BSK, perfect. This is a BSK. And BSK, this is here, you know, the octa or the Fourier domain OCT is not helpful because it stops. The light cannot go beyond this, these deposits. These are calcium deposits in the Bowman layer. So here, the Anterion or these swept source OCT is very helpful, because you can see even with this dense scar, you can see how's the iris, how's the lens, everything you can see with that. Macular dystrophy, you can do an OCT. If you have a doubt in the diagnosis, you do the OCT. If it is slightly thinner, it is macular dystrophy. In macular dystrophy, you can know where are these deposits. If these deposits are on DM also, then you will not do a DM. You'll do a penetrating keratoplasty. That's how it helps me in managing my macular dystrophy patient. Fuchs is where endothelium is defective. So you can see, or endothelial decompensation because of a phakic, pseudophakic, any kind of thing. So you can see if it is a long-standing one, you will see this bullae, the fluid which has collected under the epithelium. So this is a patient who with anterior image in one area, you can see the iris is missing. So here there was no iris. So you can see the bullae, irregular DM, and absent iris. DM folds are very nicely seen, but is just for documentation purpose. In transplant, suppose you have done a DSEC, you can see what is your thickness of your DSEC button, because it's important. If you have a rejection, the first sign will be increase in the thickness of this lenticule. So you can pick up the rejection early and treat them well. So this is a patient again who had DSEC followed by PKP. In anterior, you can see very nice from angle to angle the whole of your graft. Sometimes you have an irregular kind of thickness or dissection, that also can be picked up by this. Or if you have a graft detachment, you can see this is a octa image and this is an anterior image. And here you see that graft is attached in one area and detached in another area. So you can plan when do you want to rebubble, how much you rebubble, and you know all those. That's how it helps in managing DMAC. DMAC, you can see it's 5:1. It's very compact. But if you have a detachment, you can see even whether the orientation, which orientation the DM graft in, that also we can pick up using OCT. OCT is excellent tool when we are following up our DMAC patients, specifically if you have a challenge. So here this is a patient who had a failed graft. Even in this dense, this monochromatic laser kind of source OCT, it can penetrate. Here also I can see how thick is my graft. This is a PK, this is a hypertrophied epithelium. These are the posterior GH junction. So here you can plan what is the size of DSEC graft that you want to keep. Similarly in this. So even this patient who had a collagenolisis, vascularized corneal graft, suppose you want to plan your graft. So how it helps me is I can see, AC is pretty good. So and angles are pretty good. So I can plan my penetrating keratoplasty. I will not need to do an anterior segment reconstruction as well. Very helpful, extremely helpful. What I found is in my ocular surface patients. This is a patient who had a chemical burn. You can see bad LSCD. In your routine octa, I can't see what is down there. Suppose I'm planning a slit. If I know what is the thickness of cornea, it helps me. Suppose I know that if it's very thin, I'll keep my corneal graft ready. I'll keep my multi-layered AMG ready or whatever. So in anterior, it can penetrate. It can tell me how thick is my pannus. It can tell me how thick is my cornea and what is down there. This patient had chemical burn and he had, you can see there was a DM detachment also, which I couldn't see. So now what I have done is a one-eyed patient, very bad LSCD, I'll have to do some LO kind of surgery. So I thought that we'll do only desmetopexy. We did it just desmetopexy for him. He improved, came with the ambulatory vision, and now we are planning only DSEC. So this is how really helpful when you have a bad scar or these bad panas as well. As I said, graft rejection, the first sign is, these are KPs. The first sign is increase in thickness of this graft. I pick up my graft rejection early, treat it. That's how it's helpful. This is a patient of where you do a stromal augmentation. Suppose you have a cornea, keratoconus cornea of 350 microns, you can put up another Bowman and as well as anterior stroma, maybe 200 microns, and increase the thickness of that cornea. This is a patient of Bowman stromal inlay that we have done recently, and you can see there also, you can see how it is, how thick it is, all those things you can plan. Bowman stromal inlay, another patient. Cataract surgery, how does it help in cataract surgery? So this is a patient who had you can see lens dislocation. Here you can see the lens is dislocated. Another patient. So this patient had a post-traumatic cataract. You can see these flocules. So these, I know that I'm going to decompress it first before doing my capsulorhexis. Otherwise it will, go in the periphery. Another patient who had a developmental cataract. And here, look at this. This is a patient who had a posterior subcapsular cataract, very clearly visible. This opacity is ahead of posterior capsule. Again, another patient of PSC. Now I'll show you this patient. This patient came for a cataract surgery, total cataract. We just thought that let's do a, OCT. And what we found, you can see here, so this posterior capsule was ripped. So there was a pre-existing PCR. This was actually PPC. When we saw the other eye, this was a clear-cut PPC. You can see here. And when we did surgery, so we were very careful. So there was already pre-existing oval rhexis, oval PC rent. So that's how it helped. Otherwise, you can go ahead and the lens will fall into vitreous. A patient of iris claw lens just landing nicely on the iris. Sometimes you can even image anterior vitreous. So this, suppose you have cells in the anterior vitreous, those also you can image with that. Suppose you have post-cataract surgery, DM detachment. You can see which kind of DM detachment it is, where it is, how you are going to do desmetopexy. And this patient had a DM detachment as well as PAS. You can see there's a PAS. In this area there was PAS. So you can even image the where iris is defective, where you have done a iridectomy. And microbial keratitis, whether it's an infiltrate, edema, all those things you can. HSV is very helpful. Suppose you have a edema in the center and you do a OCT, and if the endothelium is convex instead of concave, this is almost always HSV. So you can go ahead and give your anti-HSV and steroids. Suppose it's a long-standing corneal decomposition, it will not be convex. It will remain concave, and overall thickness will increase. So here, this is really helpful. This is another patient. You can see peripheral keratitis. This portion is edematous, center is compact. Peripheral ulcerative keratitis. You can see this portion, there is a melt. Corneal thinning in severe dry eye. In this patient, we had done a multi-layered AMG. So the stroma has given and it is increased, thickness is increased. Even in scleral lens fitting, you can know what is the vault, whether it is touching the cornea or not. Do you want to increase the vault or flatten it? All those things you can plan. So, other than imaging, at least Anterior, we have is a tomographer as well. And this tomographer is extremely helpful for me when I'm imaging my steep corneas. Suppose Schlimfwick camera has a limitation. The moment you go beyond 55 diopters, it becomes unreliable. But here it is very reliable. Even with 70 diopters, 75 diopters, absolutely reliable. And this thickness map also is much more reliable than your pentacam. Specifically, suppose you have patient status post, C3R status post, PRK, those kind of things, this thickness is very good. Even the epithelial thickness map is extremely good, and it's far more predictable and far more repeatable than what we see in our OCTA. And you have an eye tracy also, you can do IUL biometry also, and biometry also is very, very good. So this is my last slide. So this is what we saw recently, a patient, and my fellow said, sir, this is like orbiculum in the eye. So what does that mean is that the crystal ball in which you see a future. So this was actually an NRID patient who had a total cataract and it came into the anterior chamber. So we did a simple cataract surgery and patient was fine. Thank you so much.